I don't think I need to tell this audience that the delivery of medical care in this country is in absolute disarray. On the one hand, since the Second World War, our ability to understand, diagnose, and treat disease has grown exponentially. We've dissected the human genome. We've developed vaccines that prevent polio, cervical cancer, and other devastating diseases. And we've built machines that allow us to explore the deepest recesses of our bodies without penetrating them. On the other hand, our ability for getting these sophisticated and advanced technologies to people in an affordable and equitable fashion is fundamentally unchanged. And this is particularly true for people living in communities with populations under 100,000, communities that are spread across most of the country. Can you believe that we rank 50th in the world in longevity? And I don't need to tell this audience that there's a growing shortage of physicians, especially primary care doctors, but also subspecialists. Indeed, by the year 2020, it's estimated that our country will have 70,000 fewer doctors than we need. And I certainly don't need to tell you all that we have 40 million people in this country without any medical coverage, and probably as many with inadequate medical insurance because they can't afford it. You're all acutely aware of these disturbing facts, and I suspect, and I have experienced that in talking with some of you during this meeting, that you've experienced, or someone in your family has experienced, the frustration of our fragmented, costly, poorly coordinated, and error-prone healthcare system. A non-system might be a more accurate term. Now, I'm a physician scientist who's been privileged to hold multiple leadership positions at the Mayo Clinic, where I've spent the majority of my career. And 8 years ago, when the story I want to tell you this morning begins, I was chairman of the largest department of medicine in the country. Also important to my story is that I ran and still run a research laboratory. And in my lab, I use mice, rats, and cell lines to study at a very basic level the diseases of the people that I see in my clinic. Equally relevant to my story is that I was also a marathon runner. So the tale begins on a beautiful spring evening after work in Rochester, Minnesota, when I was out on a training run with my close friend and physician colleague, Mike Brennan. We were ruminating, as we often did on our runs, about all of the problems in healthcare I mentioned to you at the beginning of the talk. And perhaps invigorated by the endorphins that make running conducive to creativity, or perhaps it was the pints of Guinness we were looking forward to at the end of the run, we tossed around the concept that what was needed was a totally different approach to the problems in healthcare. Perspiring and puffing, but very excited, we thought, what if? What if we could create a laboratory, a living laboratory, like my basic lab, but where instead of studying cells and mice, we'd study how healthcare is and might ultimately be delivered to people? And what if, by this different approach, we might be able to discover new insights and develop novel models of care delivery that would have the potential to rectify some of the problems of the current healthcare delivery non-system? And what if we were able to see these problems from a different perspective and employ a different type of inquiry by adapting and applying the scientific method to healthcare? So here's how that story played out. Implementation of the scientific method requires a number of important elements. It requires space, a laboratory for us to do our experiments in. It also requires expertise in a discipline. In my case, it happens to be epithelial cell biology, a discipline I learned at the Rockefeller University when I was a Mayo Foundation scholar. It requires skilled people. In my lab, the skilled people are physiologists, microscopists, and molecular biologists. And it also requires technical approaches. For example, cell isolation and cell culture. To do experiments, we need equipment. We need centrifuges, electron microscopes, and culture hoods. We also need financial support. And that's where the NIH comes in. And finally, the scientific method requires metrics. In science, it's publications, grants, and important new knowledge. So using this framework, we organized these respective elements of our what-if living laboratory with the goal of generating new insights and novel solutions to the problems of healthcare delivery. We designed space. We put it directly in our outpatient building, and we organized the space in a way to facilitate a different way of thinking and to be able to design real-time experiments focused on how healthcare providers interact with patients. We developed new expertise in the discipline of innovation. We were fortunate to have the help of Larry Keeley, the CEO of Dublin, and one of the country's acknowledged gurus in innovation. He made us aware of the spectrum of innovation, from sustaining innovation, doing what we now are doing but doing it better, to perhaps the more important type of innovation, disruptive innovation, doing things in a totally new and different way. And we also became familiar with the discipline of design thinking with the help of Tim Brown, the CEO of IDEO. This is a systematic approach to problem framing and solving that uses qualitative observational research to discover the explicit and implicit needs of individuals, in this case, our patients. We hired skilled people to populate that lab, diverse types of individuals that had never before been embedded in a healthcare system, designers from varied disciplines who brought with them deep experience in human-centered observational research. And we mixed the designers with physicians, with nurses, with project managers, with IT people, and with people from finance, a team now consisting of about 50 individuals in our center devoted entirely to discovering and implementing new ways to deliver better health. We developed technical approaches based on design thinking that depended heavily on the concepts of co-creation, rapid prototyping, and piloting. And this approach was the philosophy of our team: to think big, to start small, and to move fast. We developed a living laboratory in our outpatient setting and equipped it with video and audio devices so we could observe, with the permission of patients, the interaction of providers and patients as we explored and evaluated new models of healthcare delivery. And we did all of this with the visionary support of Mayo leaders and friends of Mayo, including an external advisory council made up of successful innovators, designers, and entrepreneurs. People like Larry Keeley, Tim Brown, and Dean Ornish, who spoke to you yesterday. And finally, we began to develop new metrics. We needed these to assess our progress in advancing the innovative healthcare models. These metrics didn't exist and needed to extend beyond money, which is a necessary but not a very good stand-in for the full spectrum of dimensions that, as you know, make up the patient-provider human experience when it comes to healthcare. So before I conclude with the lessons that I learned from this experience and provide a challenge to you, as suggested by our host, Randy, I'd like to show you a video that we prepared, which I think dramatically encapsulates the problems that we face in healthcare and suggests a potential general solution. Let me conclude then with a few closing remarks about the lessons that I learned and the challenges that I propose. So the lesson that I took away from this what-if experience of adapting the scientific method to discover and test new ways to deliver health care, employing the disciplines of innovation and design thinking, was best articulated over 50 years ago by arguably the greatest thinker of the 21st century, Albert Einstein. Einstein said, we can't solve problems by using the same kind of thinking we used when we created them. And I'd like to suggest that the approach I've outlined to you this morning is consistent with a new way of thinking about healthcare problems. Now, in the early 20th century, the Mayo brothers often spoke about a union of forces, the idea that medicine was a profession of teams, all unified by the value that the needs of the patient come first. They believed in this concept so powerfully that they made it the cornerstone of their practice, and it remains the unique and defining characteristic of Mayo Clinic today. I'm not sure the Mayo brothers could anticipate the diversity of people we have working in our Center for Innovation in this first decade of the 21st century, but I think they'd approve, because they knew the way to solve difficult problems was to have diverse, smart, passionate, and committed people, people like all of you in the audience. That's why you're here. Risk takers who are uncomfortable with the status quo, change agents who want to do things differently, who remain inspired by the past but focused on innovating for the future. So the challenge I suggest to you today, to all of us, is this. Let's begin by acknowledging that the problems of the healthcare delivery non-system affect all of us, that we all have a responsibility to participate in and contribute to a union of forces to solve these problems. The question that I leave you with is, how can all of us here now begin to organize a union of forces that needs to come together to fix healthcare? Imagine what if we could do that. Thank you very much.